Good evening, all. I am Arpita from IGCP. Today, before we move on to the topic, I would like to introduce our speaker, who is a very eminent figure in the medical fraternity. Today, we have with us Professor Dr. Kiran Godse sir. Sir has done MD, PhD, FRCP from Glasgow, is a renowned dermatologist and respected academician. He is professor of dermatology at D.Y. Patil University School of Medicine, Navi Mumbai, and also practices at Apollo Hospital, Navi Mumbai. Dr. Godse has made significant contributions to dermatology, particularly in the area of urticaria and allergic skin disorders. He has served in several leadership positions, including being the president of the Indian Association of Dermatologists, Venereologists, and Leprologists (IADVL) in 2020, one of the largest dermatology associations globally. Today, he will be enlightening us on the topic Urticaria Unmasked Beyond the Itch Towards the Cure, a subject that promises great insights into understanding and managing this challenging condition. This session will focus not just on the bothersome itch, but also on the underlying mechanism, latest treatment option, and pathways toward long-term relief. It will help us look beyond symptomatic care and explore a more holistic approach to cure. Please join me in welcome Professor Dr. Gorse. Welcome, sir. And now I would request you to please start with the topic. Over to you, sir.
Hello and good evening, and welcome to this session on Urticaria Unmasked. We will be telling you about what is urticaria, how it is treated, what are the investigations to be done, and what is new in urticaria. So, I am from D.Y. Patil University, Navi Mumbai. There are no conflicts of interest. So, urticaria is a dermatological disorder characterized by sudden appearance of itchy hives, wheals, angioedema, or both. A hives or a red wheal consists of size varying from 2 to 20 centimeters with itching, burning, and it resolves in 24 hours. Angioedema is typically characterized by sudden pronounced swelling of the lower dermis and subcutis. It is sometimes painful and less of itching. It frequently involves mucous membrane like lips, palms, and soles, and it takes up to 72 hours for resolution. So, urticaria is easily diagnosed but difficult to treat. Urticaria can be classified based on the duration, frequency, and cause. So, as you know, acute and chronic is the classification. Acute is symptoms for less than 6 weeks, and chronic is symptoms daily or almost daily for more than 6 weeks. Chronic is further divided into spontaneous, where there is no obvious trigger, and inducible, where symptoms are induced by specific trigger like temperature, pressure, or heat. Spontaneous is further divided into various causes like autoimmune, autoallergic, infection, and unknown causes. The emerging endotypes of chronic spontaneous urticaria are autoimmunity type 1 and type 2. Type 1 is an autoallergic phenomena where body's self-allergen causes histamine release. Autoimmunity type 2 is traditional autoimmunity where two autoantibodies trigger mast cell to release histamine. As you know, CSU is a mast cell dependent disease. Aberrant mast cell activation and degranulation is central to the pathophysiology of CSU. The mast cells can be degranulated by autoantigen or autoallergic mechanism as shown here. Autoimmune mechanism is type 2b where two autoantibodies trigger mast cell via Fc epsilon R1. And the other pathway is MRGPRX2 where other endogenous and exogenous ligand trigger mast cell to release various mediators like histamine, tryptase, PAF, leukotrienes, prostaglandins, etc. And the final appearance is pruritus, erythema, edema, and infiltrate. So, autoallergic urticaria is common type where auto IgE against TPO, TG, interleukin 24, dsDNA are the one which trigger mast cell. In type 2b, it is an auto IgG type against Ig and Fc epsilon R1. Diagnosis of autoallergic is by specific Ig to autoallergens and total IgE. In autoimmunity, the diagnosis is by autologous serum skin test and Western blot or ELISA. Total Ig is normal or high in autoallergic and low in autoimmune type. Disease is less severe in autoallergic and concomitant allergic diseases are common. Most patients with autoimmune chronic spontaneous urticaria also have autoallergic urticaria, but not vice versa. So a combination can exist which makes diagnosis little difficult. Urticaria activity score is a simple measure score to measure the severity of urticaria. One has to measure hives number on that day, say less than 20, 20 to 50 or more than 50, and number they get rating as 1, 2, 3. Similarly, each can be graded as mild, moderate, severe. Maximum in each UA score is 6 per day or 42 in a week. So, a 28 to 42 US score in a week is a severe urticaria, and US of 7 to 15 is a mild urticaria. Urticaria control test is a 4 questionnaires in last 4 weeks how patient has shown the response to urticarial medicines, and total score of more than 12 indicates urticaria is under control. CSU is a chronic disease of duration averaging 1 to 5 years. 50% will resolve within 6 months of onset, 20% will resolve in 3 years, and another 20% will resolve in 5 to 10 years. And less than 2% will have urticaria up to 25 years and more. The factors which determine the severity of the disease are those mentioned here, like somebody having a severe disease, longer duration, females, and age more than 50. Concurrent angioedema and inducible urticaria, BMI more than 32, smokers, NSAID hypersensitivity, associated asthma, rhinitis, and polypharmacy. All these factors can make urticaria a severe urticaria and they need beyond antihistamines. Urticaria is a bad disease because patients can't sleep well, can't concentrate, can't work normally, becomes moody and irritable, and stop doing fun things. So, urticaria is challenging to manage and substantially affects quality of life beyond skin. It can affect physical, socio-economical, emotional, psychological, and role function relationship, all spheres of life. Meaningful patient-physician engagement is needed to support individualized treatment that addresses unmet emotional and holistic care needs, in addition to effective disease and symptom control. These are the guidelines of 2020, which clearly state the start treatment of urticaria with modern second generation H1 antihistamines with single tablet. If no response, you can make it 2 tablets per day. If no response, you can make it 4 tablets. If still patient is not responding, you can add omalizumab 300 mg every 4 weeks. If needed, increase the dose or shorter interval. And third line is cyclosporin. Short courses of systemic steroids may be used at all times if exacerbation demanded. So these guidelines clearly state that standard treatment is non-steroidal antihistamines. But important is a single dose will be effective only in less than 50% patients. Increasing dose will improve the response, but again 25 to 30% patient will remain symptomatic. So even updosing, all patients may not respond, 25% will need something else. Omalizumab addition will improve the efficacy up to 80%. Again, few patients may require cyclosporin. So it's important that specialist or doctor understand that how his patient's urticaria is under control. These are the Indian guidelines which are similar to the international guidelines. Only here, what we have done is, what we can do is you can add H2 antihistamines like ranitidine and leukotriene antagonists like montelukast in addition to updosing. And other options like methotrexate, dapsone, autoserum therapy can be used. The urticaria control test will determine whether to increase the dose or stop the dose. If urticaria is completely controlled, that UCT is 16, you may consider step down therapy. But if UCT is less than 12, uncontrolled disease, you need to step up the dose. So, a non-responder antihistaminics will have higher US score, higher CRP, higher D-dimer level, previous treatment with steroids, concomitant inducible urticaria, and low quality of life. Low total IgE patients will respond better to cyclosporine. Now, these are the antihistaminics we have. We suggest to use only modern second generation antihistaminics like bilastine, levocetirizine, desloratadine, fexofenadine, cetirizine, and loratadine. We do not use older antihistaminics like chlorpheniramine, terfenadine, or hydroxyzine. Why we say that? Because brain H1 occupancy level is very low with bilastine and fexofenadine. So these are the truly non-sedating antihistaminics which can be used in most of the patients. Sedation with antihistaminics create poor sleep architecture. As you can see, a first generation antihistaminics does control the disease, but it can make patient drowsy and sleepy throughout the day. Omalizumab is an anti-IgE biologic which prevents angioedema, improves quality of life, and is suitable for long term. It is available as 150 to 300 mg vials, to given subcutaneously, and we have a biosimilar available in India. All patients may not respond to omalizumab. Patients with BMI more than 32, aggravation of CSU after omalizumab, low Ig, low basopenia, positive anti-TPO, these patients will take longer time to respond. So here, a combination of cyclosporine and methotrexate can be used along with cyclosporine. Cyclosporine is an immunosuppressant and can be used up to 3 to 5 mg per kg. It is a direct mast cell mediator release inhibitor. You need to check CBC, creatinine, and blood pressure. Ideally, you can start with 200 mg in first month, 100 mg in second month, and 50 mg in third month. And then you can try weekly pulse of 200 mg Saturday, Sunday. Other way is to give 5 mg per kg and stop at the 3 to 6 months. We cannot give cyclosporine beyond 1 year. Corticosteroid can be used 20 to 30 mg for 5 to 10 days because of severe worsening. Or a weekly pulse can be tried. Again, long-term treatment of corticosteroid is not advisable. How do you work up? You need to diagnose, you to rule out the inflammation and measure the activity. So these are the 4 tests you must do in all urticaria patients: CBC, CRP or ESR, total IgE, and IgG anti-TPO. IgE is often elevated in urticaria patients, but low levels also can occur. So high total IgE is an indicator of autoallergic urticaria, and patient will respond better to antihistaminics and omalizumab. Low Ig, that is less than 50 IU per ml, is an indicator of autoimmune urticaria where patient will respond better to cyclosporine. Thus, Ig is a valuable marker, but do not keep on repeating Ig every month. CRP is linked to urticaria activity and inflammatory markers. So, high CRP is an indicator of patient will not respond to antihistaminics and may need cyclosporine or something else. In CBC, a 5-part cell differential cell counter, you can see a basopenia, which is a well documented and it is related to urticaria severity. So blood basopenia 0 is indicator of autoimmune urticaria. Similarly, eosinopenia is an indicator of high disease activity and autoimmunity type 2. Similarly, elevated mean platelet volume and lymphopenia are marker of autoimmune urticaria. IgG anti-TPO again is a marker of autoimmunity. Similarly, patient with low IgE and positive anti-TPO titer is a best surrogate marker for chronic urticaria autoimmunity type 2. What else you need to do? You need to avoid few drugs, look for the infection, look for the thyroid hormone autoantibodies, look for allergen avoidance if patient is getting worsening, look for serum tryptase if patient has got mastocytosis, and lesional skin biopsy if a urticaria lesion is lasting more than 24 hours. A biopsy is a must. You need to confirm diagnosis, look for the cause, look for the cofactors, look for the comorbidities, look for the consequences, components, and course. Monitor activity with urticaria activity score and UCT. So this is the algorithm for diagnosis of urticaria. So urticaria patients, if they are associated with unexplained fever, joint pain, bone pain, malaise, please think of autoinflammatory syndrome, although they are rare. If hives are lasting more than 24 hours, think of vasculitis and do a biopsy. If symptoms are inducible, like in dermographism, consider inducible urticaria. Otherwise, your diagnosis of chronic spontaneous urticaria can be made. On angioedema, please ask for ACE inhibitors because ACE inhibitors can induce angioedema. If angioedema associated without urticaria, please think of hereditary angioedema, which is a totally different disease. Other options are Montelukast, ranitidine, methotrexate, dapsone, autoserum therapy, and doxepin. Montelukast can be used 10 mg per day in respiratory allergy and in NSAID-induced urticaria, along with H1 antihistamines. H2 antihistamines have got less evidence but worth adding ranitidine 150 mg twice a day, which is a safe and economical options. So this is my 7-tablet formula for CSU, and I can assure you that if you give this 7 tablets, almost 70% of your patient will come under control. You need to give 4 tablets of H1 antihistaminics. 2 in the morning should be either bilastine or fexofenadine. 2 in the evening should be leocetrizine or loratadine. 2 tablets of H2 antihistaminics like ranitidine can be added, and 1 tablet of Montelukast. Similarly, you can add vitamin D3 in most of Indian patients. You give vitamin D once a week for 8 weeks and once a month lifetime. And a B12 deficiency is common in Indian vegetarian patient. You give B12 tablets 3 months on and 3 months off because both have role in control of urticaria. Methotrexate can be given 10 to 15 milligram per week along with folic acid. Please check CBC and LFT. It's a slow response. It will not act fast. It takes at least 6 weeks to show the response. Mycophenolate mofetil is a antimetabolite which can be used 1 to 2 grams per day. Dapsone has been effective in urticaria vasculitis and delayed patient urticaria. You can give 100 milligram per day. Again, you need to do CBC and G6PD levels. All these are in addition to for your 4 tablets of antihistamines. Autoserum therapy is involving parenteral, intramuscular, or subcutaneous injection of autologous blood or serum in an attempt to desensitize patients to pro-urticarial factors in patient serum. So what we give is collect blood and separate serum, inject 2 to 3 cc every week intramuscularly or subcutaneously for 9 weeks. 30% patient will respond and most of the patient like injection therapy. So it's a easy, simple therapy. You can use it. You need a good centrifuge and blood collection device. In children, we suggest to use the same algorithm like in adults. That is, you start with a standard dose of antihistaminics. If no response, you make it 2. If no response, make it 4. So standard dose could be due to age, weight adjusted. So maybe 2.5 ml of serum in the morning. If no response, you can make it twice a day or 4 times. In pregnant and lactating women, loratadine, leocetrizine, cetirizine, desloratadine, and fexofenadine are safe, but we do not advise updosing in pregnant and lactating women. Urticaria in pregnancy may show worsening in 1/3 of the patients. They need antihistaminics. 1/3 patients may show good response to antihistaminics, and 1/3 patients may urticaria may disappear in pregnancy. So pregnancy and lactating, you can give standard antihistaminics in standard doses, but no updosing is advisable. What is new in urticaria is there are a variety of newer medicines available like dupilumab, which is being approved for urticaria in USA, remibrutinib, which is a BTK inhibitor, which is also will soon be approved for urticaria. So these two are the newer drugs for urticaria, which will come into Indian market in few years. There are various other drugs which are being under investigations, like benralizumab, secukinumab, or bimekizumab. But as on today, we just have a omalizumab to treat urticaria when standard treatment do not show good response. Summarizing, second generation antihistaminics with updosing is the first line therapy in urticaria patients. Omalizumab with updosing is second line therapy, and cyclosporin is a third line therapy based on the evidence. There is a cruise control app available freely downloadable to control urticaria. You can download it and do daily monitoring by adding urticaria activity score. And the dedicated Indian Journal of Skin Allergy for urticaria and related disorders. Thank you very much for patient listening, and I'll be happy to take questions.
Thank you, sir, for the insightful talk. So, with your permission, can we take the questions from audience, sir?
Yeah, please.
I would request all the esteemed doctors who have joined us today kindly put your questions in the chat option so that I can read them off to sir. So the first question that has come to us is from Dr. Munainin. He wants to know, how do you rule out differential diagnosis such as mastocytosis, vascularitis, or angioedema?
Yeah, very good question. So remember, vasculitis, tell the patient to take the photograph of arterial lesion single spot every 12 hourly. So at the end of 36 hours, even if you see an arterial patch which is still there, not disappeared, please think of vasculitis and a skin biopsy is needed to confirm the diagnosis. Mastocytosis is a condition where patient may get variety of arterial wheals and pigmentation. Again, a biopsy is required to confirm the diagnosis and serum tryptase level can be done. Angioedema is where patient get deep swelling of the lips, hands and feet, and this swelling can actually give patient trouble. So here diagnosis is clinical, but again I reiterate, angioedema without an urticaria, you need to consider a hereditary angioedema as a cause. Other causes of angioedema like NSAIDs, painkiller tablets, ACE inhibitors and gliptins can also cause urticaria and angioedema. So all these are important when you come to a diagnosis of urticaria. Thank you.
Thank you so much, sir. Next question is from Dr. Puneet. So, how do you manage patients with antihistamine refractory urticaria?
Yeah, so when you say antihistaminic refractory, what it means is we are given 4 tablets of antihistaminics, 2 in the morning and 2 in the evening, either bilastine or fexofenone in the morning and levocetirizine or loratadine in the night. In spite of taking 4 tablets, if patient continues to get hives, that means the patient is antihistaminic resistance. So the best treatment as per the evidence is omalizumab, but it's a costly medicine costing around 12 to 15,000 per injection. Other option is to give cyclosporine 3 to 4 mg per kg for 1 to 3 months. Or you can also try methotrexate, dapsone, azathioprine, mycophenolate mofetil, and autoserum therapy. These are all, they do work in urticaria, but the evidence is less. So the best treatment after 4 tablets is omalizumab as per the guidelines. Thank you.
Thank you once again, sir. Next question is, what is the current role of biologics such as omalizumab in a chronic spontaneous urticaria?
Yeah, so omalizumab has actually changed how we treat urticaria because it's a targeted treatment. It is a drug which is not immunosuppressant, it's an immunomodulator. You can safely give in patients, even during COVID time, we used to give it because it is not an immunosuppressant. Dose is 300 mg once a month for at least 3 to 6 months. Autoallergic patient will respond better and autoimmune patients will take longer time to respond. Generally, patients need to take injection and keep the patient in the hospital for 2 hours. Look for the blood pressure pulse because rarely an anaphylactic reaction can occur. But otherwise, it's a safe drug. Patient can get good response. Biologics does not mean cure of the disease. When you give omalizumab, you get a better quality of life and a long-term remission. So please understand the biologics have changed how you treat the disease, but obviously cure is a far-fetched dream as on today. But as on today, we have biosimilar of omalizumab available, which is little economical and which you can try. Thank you.
Thank you so much, sir. We have the next question from Dr. Subhash sir. He is writing that, sir, I am a general physician and patients who come to me with urticaria, I have a compromised quality of life, mental health, and sleep. So, how should I tackle them and when should I refer the patients to dermatologist?
Yeah, so we expect that a family physician should be able to treat urticaria because when you give the updosing 4 tablets of urticaria, almost two-thirds of your patient will respond. So you can use my 7 tablet formula, which I just told you, 4 tablets of antihistaminics, 2 in the morning and 2 in the evening with ranitidine and montelukast. In spite of that, if patient is not responding, you can consider referring it to a consultant dermatologist for giving either omalizumab or cyclosporine. I understand most of the patients do have bad quality of life. They can't sleep well. Many times the anxiety is also there. So addition of hydroxyzine or a antidepressant in the night sometimes helps for these patients because they are really frustrated with the disease. But you can treat most of the urticaria patient by giving standard therapies. Let me tell you that all the antihistaminics which are available in India are available in double strength. Like we have got bilastine in double strength, we have got levocetirizine in double strength, desloratadine in double strength, and cetirizine in double strength. So it's very easy to give double strength of bilastine in the morning and double strength of levocetirizine in the night. That's the best combination to treat most of the urticaria. Please understand that levocetirizine can cause sedation in 10 to 20% of patients. So that you need to tell the patient, but otherwise you can give same bilastine tablet 40 mg twice a day also to control urticaria. Thank you.
So one last query. The question is from Dr. Rakesh. He's saying that I practice in a very resource limited setting. So what pragmatic approaches can clinicians employ when advanced therapies are not available?
Yeah, so obviously at the periphery you will not have biologics available, but what we can have and what is being preferred is after updosing 4 tablets, you can consider auto serum therapy, which I do understand is simple. You just need a good centrifuge and a blood collection plain vacuum. Collect blood in a plain vacuum, 5 cc, spin it in centrifuge for 5 to 10 minutes. You will get a serum. You take out the serum and inject intramuscularly in the patient once a week for 9 weeks. It also helps, and it's an add-on therapy. We call it a poor man's biologic because it is the principle is same. It targets the root cause of urticaria. Obviously, you can give short courses of steroids if there is a worsening of the disease, and you can also consider giving immunosuppressant if you are well versed with, like methotrexate, azathioprine, or dapsone can be given. But I do understand the resources are limited at the periphery and in the small clinics. Thank you.
Thank you so much, sir. Thank you so much once again for answering all the queries. I would like to wrap up the session today, but before that, I would like to thank you, sir, on behalf of the entire IGCP team. Thank you for your insightful and enlightening talk. Your talk in this very important topic of urticaria has truly deepened our understanding of this challenging condition and its management. So, we are really grateful for your time, your expertise, and for sharing your practical knowledge with all of us today. Thank you. Thank you so much, sir, once again.
Thank you very
Thank you.
much and bye bye.
Bye, sir. Take care. Thank you, everyone, for joining, for putting your questions and making the session an engaging one. Thank you all. We are concluding here.
Thank you.